You know, it's a delight to be here. Actually, those of us who have been on this podium this morning get asked to speak at lots of different events, as do I. And I can tell you, getting to speak at this event every year is one of my absolute favorites. This is the best audience you could ask for as somebody who does what I do. So I'm very happy to be with you. It's an honor to be with you. I'm going to talk a little bit today about topics that my research career has kind of been morphing into over the past few years. I've gotten interested in survival issues, which are a little bit different from sort of the traditional research things we talk about, you know, like chemotherapy and surgery and that sort of thing. So I've started moving into that direction, and I wear several hats, actually, that prompt me in that fashion, both locally in New Orleans and on a national level. So I've really been spending a lot of time on this area for the past 3 or 4 years. I think all of you know most gynecologic cancer survivors start experiencing side effects of their treatment almost from day one. You know, when you go through surgery for the first time. Obviously, there are a variety of immediate side effects that everybody's familiar with. There's some more delayed things that you may not think about. You know, things like menopause, as we heard, or lymphedema. In fact, I'll give a little plug for my buddy, Dr. Rich Barakat, who is now doing a study on lymphedema in gynecologic cancer patients, the so-called LEG study, to try to figure out exactly what the risk and the impact and the incidence of lymphedema is. You know, we hear about lymphedema in breast cancer patients all the time, but without question, it affects our GYN cancer survivors as well. So we want to try to find out more about that. I'm not going to talk about that specifically so much today as I am going to talk about some of the side effects of the other treatments that we use for GYN cancers, mostly the chemotherapies that we use. And again, there's some immediate side effects that we're all aware of, you know, the myelosuppression or bone marrow suppression and hair loss and nausea and all of those things. But there's some delayed side effects that are actually more challenging in some ways to deal with. You know, women go through, again, menopause, even if you haven't had your ovaries removed surgically, not infrequently taking chemotherapy, and I know I'm doing something wrong because it keeps flashing, but I don't know what it is. I think we got it now. At any rate, so chemotherapy itself can cause the ovaries to cease functioning. So we deal with those things. Loss of sexual function sometimes as a result of loss of ovarian function. A couple of the things that are of particular interest, I think, probably to most of the people in this room, and that have become an interest of mine, are peripheral neuropathy and cognitive dysfunction, otherwise known as ChemoBrain in the lay community. And you might wonder, why is it that the side effects seem to be so bad for our GYN cancer survivors? And they really are. They're actually a little more profound in GYN cancers than in some others. And I didn't do it that time, but it's still flashing. At any rate, here's some of the reasons. Typically, we treat our patients for a long time. Some of our regimens, as you all may know, go even a year or more of chemotherapy. Some of the drugs we use are just notorious for long-term side effects. You know, most of our regimens include some combination of the drug cisplatin or the drug carboplatin or paclitaxel or Taxol. And then many of our patients actually receive multiple regimens. Now, there's some patients are on regimen after regimen after regimen, maybe for the rest of their lives. And then finally, unfortunately, we have not been able to take advantage as much of the new molecularly targeted agents as some of the other cancers do. Those agents that have minimal toxicity are terrific, but unfortunately, we've only made really minimal use of them. However, we have tried to deal with some of these problems in various ways. Peripheral neuropathy is seen in probably somewhere around 40% or so of the patients who receive the kinds of chemotherapy that we use, and it's characterized by numbness or sometimes pain or hypersensitivity to cold. One of the things that patients frequently tell me is that if they have a pre-existing arthritis, you know, in a specific joint, that they'll notice that that gets worse with neuropathy. It typically starts in the tips of the fingers and the tips of the toes and progresses sort of upstream, in effect, or proximately. The agents that really are most associated with peripheral neuropathy again, are the ones that we use all the time, unfortunately, Taxol and cisplatin and carboplatin. And it typically, that is the neuropathy, will typically last through the duration of treatment, but for reasons we don't really understand, it often progresses through treatment or beyond it, even after you've stopped. Some people will have it resolve eventually, but some people, again, for reasons we don't understand, it's permanent. And we don't know how to fix that any more than we know how to fix the slide projector. The things neuropathy does then, the sort of secondary things, it obviously affects quality of life. It can cause or be associated with depression and sleep disturbance. And unfortunately, we really don't have a specific, consistent treatment right now for that problem. We've tried a lot of things. You know, many people have taken Neurontin or gabapentin. We've tried all the other things you see on the list here with varying success. Some people get some benefit from some of these agents some of the time. But there isn't anything I can tell you I can prescribe to you right now that I can promise you will get rid of peripheral neuropathy. Well, to that end, we've been trying to figure out a way to treat neuropathy. In our large NCI-sponsored research group, that's the Gynecologic Oncology Group, we actually did a trial of an agent for the treatment of peripheral neuropathy, and that was the drug amifostine. Some of you may have heard about this trial. It was actually finished just a few years ago, and it was for women who suffered neuropathy after taking chemotherapy for ovarian cancer. And despite the fact that patients tell us all the time that neuropathy is an issue, that trial was a flop. You know, we went nowhere with that. There were 34 people enrolled to that trial. We wanted to enroll something like 200. It took us 5 years to get that far, and we finally just gave up and closed the book on that because we simply couldn't get patients to enroll to that. So we learned some lessons about trying to learn about the side effects of cancers. It's a little different doing research in side effects of cancer therapy than in treatment of cancer, and we started to learn that. Some of the things we learned: amifostine is difficult to deal with. It's difficult to administer. It's hard to tolerate. You have to be flat on your back. You have to have an IV in place. It is as nauseating as cisplatin is, so you have to get nausea agents. So it's difficult for patients to deal with. It does seem to prevent peripheral neuropathy, and in some cases, it can be remarkably effective, almost like biblically effective, in the sense that I think most of us who have used amifostine have found patients who really couldn't walk and suddenly, after taking a few treatments of amifostine, regained that ability. So it does work, particularly for the most severely affected people. But what we realized is that women with ovarian cancer generally, while they're concerned about neuropathy, they don't consider prophylaxis for neuropathy to be a priority while they're taking treatment. And we didn't get that at first. They said the priority for most people when they're taking treatment is beating the disease. It's not dealing with the side effects of the treatment. So what we realized, therefore, was that really only the severely affected people probably are going to go to the trouble to take treatment for peripheral neuropathy, particularly if amifostine's our only option. The bottom line is we may not be able to do another trial of an agent for peripheral neuropathy, unfortunately, because of the bad outcome of this trial, unless we can find another agent that is much easier to deal with and much easier to administer than amifostine is. And there are several of those that are kind of under consideration at this point, but nothing specifically right now that we can tell you will work for sure. Let me tell you then about another side effect of chemotherapy treatments that we've actually been somewhat more successful in dealing with. Most of you have heard of, at least, the concept of ChemoBrain, or post-chemotherapy cognitive impairment is our scientific name for it. It includes things like changes in memory, in fluency, in motor coordination, all kinds of things to do with central nervous system function. At least 40% of patients report that. It was first reported in patients with breast cancer, but it's also been reported in patients with prostate cancer and ovarian cancer. We've had a hard time defining what ChemoBrain is because it's related to a lot of the things that our patients have all the time anyway. They're obviously under a lot of stress. Many of our patients experience depression at some time during their treatment and anxiety, and it's sometimes hard to tease those out from what is really the ChemoBrain or cognitive dysfunction concept. It may be some sort of directly toxic effect of the chemotherapy on the brain. We don't know that. We're going to try again.
Well, they are, but just so they can follow along in their books with
Oh,
you while
okay.
they're trying to fix it. Do you mind if we just update everybody where you are?
Sure.
And then you could say next slide so that they could.
Oh, okay, that's a good
follow along.
thing.
How about that?
Yeah,
Okay.
you bet.
So right now, and that's dead too. Right now he's on
That
page
went away, too.
54, the bottom slide. And then what I'll ask Dr. Robinson to do is, as he's moving to the next slide, at least you could read along.
Yeah.
He'll just say next slide.
Oh,
'cause
you bet.
He's got it on the computer. You just don't
Is it
have it
still
on the
not
projector.
coming up out there?
It's still not.
Oh, gee. Okay.
Okay, so
All right,
for
so
those
that's
of you
where
that
we
want to
are
follow
now.
along. Okay.
All right, the one you see on the projector now is where I'm speaking from.
Page
54. You know what? I don't have the number, though, on here. Next slide. Okay, got it. Next slide. All right. So at any rate, we don't know exactly how chemotherapy causes ChemoBrain. Unfortunately, another problem is because, as we mentioned, many women go through menopause during treatment in some form or fashion. It's hard to tell. Maybe there's some hormonal response. Maybe we're missing out on it. We know that in men who get treatment for prostate cancer, the same thing happens. In other words, when they start lacking testosterone, the same symptoms start arising. Or could it be that it's damage to the visual nerves or auditory nerves? In other words, if you can't see and hear, it's very difficult to process the world around you, and that may manifest itself as a cognitive dysfunction as well. So next slide. The reports of ChemoBrain or cognitive dysfunction, yeah, that's it, have not been around all that long. Only in the 90s, late 90s, did we first start to see reports in the scientific literature about ChemoBrain. And like I said, it was originally found in or reported at least, in breast cancer survivors. However, a couple of years back, we did start to see reports of cognitive dysfunction in women with ovarian cancer as well. So it's certainly not limited to any one particular group of cancer survivors. Next slide. One of the problems that we have with ChemoBrain, that's it, is that it's hard to measure. You know, it's not like survival where we can measure it by the day. How do you measure ChemoBrain just exactly? Obviously, we know it exists, but how do you put a number on it? Because the problem is, we can't treat something in the medical world unless we can somehow quantify it, unless we can measure it somehow. So there have been all kinds of attempts to quantify ChemoBrain, and these that are listed on this slide are some of the attempts that have been made. And unfortunately, most of those have not been terribly effective because it is so hard to quantify the function of the brain. It's just very difficult to do that. Most of them have been relatively unreliable or unreproducible is the biggest problem. In fact, many of these tests that we've tried to give patients, which are basically like questionnaire type evaluations, are not even reproducible in the same patient. In other words, if you give it to an individual one day and they answer it, then you give it to them again the next day, the degree of dysfunction that you measure seems to be completely different. So it's very difficult to figure out how to deal with the measurement of ChemoBrain. Well, we tried a sort of a different approach in the function of a gynecologic oncology group trial. And that is, we actually looked not at the chemo literature, not at the cancer literature, but at the trauma literature. We actually looked at the literature of patients who had had head trauma from accidents. And we found actually what appeared to be a very effective tool using a HeadMinder, that's the name of it, software that is a very effective way, they found in the trauma literature, of measuring cognitive deficit. So we decided to apply that, a group of us in the GOG decided to apply that to our patients with ChemoBrain to see if it would help. And we did a pilot study of that was seemed to show that the HeadMinder technique was very effective. In it, the patients used computer terminals that went online in-house, in other words, in their treatment facility. And in that pilot study, we found something like 80% of the patients actually suffered at least some cognitive dysfunction. Next slide. Based on that, we created what some of you may have heard of. It was called GOG 256, or Cognitive Function During Chemotherapy Treatment for Ovarian, Peritoneal, or Fallopian Tube Cancer. We actually put 240 subjects on that trial, and that trial, in contrast to the neuropathy trial, accrued extremely rapidly. Patients were clamoring to participate in the ChemoBrain trial. We opened it to 17 institutions, and it was closed for accrual before we knew it. In fact, before some of the institutions could even get the study open, we were having so many patients come into it that the accrual filled up. Basically, it was a study using the HeadMinder online or software apparatus for subject-reported or doing it themselves measurements of cognitive dysfunction. In other words, you could sit in your house, you could do it at midnight if you wanted to, while you're having a cup of coffee or drinking a beer, I guess, and do this online at your convenience. So it was much different from when we used the old questionnaires where you sat in the doctor's office and the research nurse was sitting beside you, kind of coaching you through it. This is a much different experience from that. And our results were much different also. We actually assessed 4 times total at baseline, that is before patients started chemotherapy, 3 months in, 6 months in, and 12 months in, and we tested processing speed, motor reaction time, and attention. And in that way, every subject was her own control. In other words, your baseline was what we compared the subsequent measurements to. So we had a time point of 0 that we can compare cognitive function to over time, which was another big advantage in this study. We measured several things associated with chemotherapy and ovarian cancer, including things like age and education and the way we administered the chemotherapy and so forth. And I keep forgetting to say next slide, but we're on the slide that says measuring ChemoBrain in women with ovarian cancer. And I'm sorry, I keep forgetting to do that. And unfortunately, I don't have the numbers on my slide. Thank you. So anybody, if I forget, just holler it out. Okay, next slide. Okay, there you go. So the median age in the study was 59 years old, so about what ovarian cancer patients average, and it was about average for everything else, that is race and stage and the way the chemo was given. So these were typical patients with ovarian cancer in the United States. And next slide, and this is a big chart that you may not be able to see very well, but basically the bottom line was, we documented that ChemoBrain, or cognitive dysfunction, does occur. In other words, there it went, sort of. And particularly, what would you guess the biggest deficit in ChemoBrain was? Anybody take a guess at it? Memory, far and away. It was memory. Motor function was also, there was also a deficit in motor function, but it was considerably less than in memory. If you controlled for things like depression and anxiety and all those things, you still found that there was a deficit in memory and motor function in women who took chemotherapy, and that change went down over time and persisted for at least a year. So we do believe, based on that, and next slide, that cognitive dysfunction secondary to chemotherapy does exist. It's not related to age, it's not related to ethnicity, education, anything else about the treatment or about the patient. One thing we did find is that in one of the domains we tested, and that was attention processing, in other words, your ability, the patient's ability to focus on a specific task, we did find that that was affected by anxiety and depression. And that kind of makes sense. You may have a hard time focusing if you're nervous about when your next chemotherapy treatment is going to be. And so that kind of made sense to us. Next slide. So in summary, this study was the first real prospective study of what we call cognitive dysfunction in women with ovarian cancer. We presented it this past March at our society's annual meeting. It got picked up by several news services and, in fact, was publicized internationally. Bottom line was at least 30% of the women, or almost a third of the women with ovarian cancer who took chemotherapy, had a decline in at least one domain or one part, one measurement of their cognitive function. And the most common decline, actually I misspelled that there, it is memory, in fact, rather than attention. Anxiety and depression, and next slide, may be associated with that, but particularly for memory, as it doesn't seem to be. We did not specifically attempt to relate this to quality of life per se. And some of you may have participated in so-called quality of life studies, which is sort of a bigger issue than just cognitive neuropathy. And we didn't even try to do that because what we wanted to do was to first just document that we could define and measure what ChemoBrain is. And this data is actually very similar to that that's been reported in women with breast cancer. So we feel very confident about the data regarding ChemoBrain so far. Next slide. So what did we learn from that was different from our study of neuropathy? In other words, why is it that we can study ChemoBrain in women with ovarian cancer, but we can't study as easily neuropathy? Well, number one, we realized we can quantitatively measure ChemoBrain very easily. And the reasons are that the patients are very willing to participate in these kinds of trials. In other words, as I said, patients were clamoring to get on these trials. In fact, we had reports from some of my colleagues who said that their patients were asking them specifically, won't you open the ChemoBrain trial here so I can be in it? So it's a very, our patients were very enthusiastic about it. We also believe, based on this, that it's possible to do an interventional trial. In other words, to try to treat or prevent ChemoBrain also. However, the downside of it is it's very difficult to get funding. In other words, to get this kind of a trial paid for. Unlike our chemotherapy drugs, which are typically owned by a big pharma company, the agents that we might use for ChemoBrain treatment are usually like things over the counter, like omega-3 fatty acid or fish oil or various other things for which there's no significant profit for any industry. So the industries typically are not very interested in supporting ChemoBrain type studies. So we've learned that instead of doing it the way we do with our treatment studies, we have to kind of think out of the box about doing ChemoBrain studies. We have to find other ways to fund it. We have to find other ways to offer it to patients. In other words, instead of having our research nurses go out in the community and talk to patients individually, this is a study where patients can do it themselves. In other words, in theory, for this study, the patients could have our patients suffering with ovarian cancer could interact with the doctors and nurses only one time, and then they can do all the rest of the study themselves at home and not necessarily have to come in at all. So we're learning how to move this kind of a study into a more patient-friendly setting so that we can get a more accurate response. And like I said, we're learning that the way to get funding for this kind of a trial is not going to be one of the traditional methods. We're probably going to have to do things like go to private philanthropists or that sort of thing to fund this kind of a trial. So in fact, any of you all out there who know anybody who wants to put up about $500,000 to do a ChemoBrain trial, just let me know after the show, after my talk today. Or better yet, you can let me know tonight when you come to Penn Social at 7:30 when my band, NED, is going to play for everybody, that rock and roll band that everybody's been talking about. That's the other hat I wear. I've been told to model the NED t-shirt. So that's the back, and that's the front. And that's really all I had. So I'm going to stop, and thank you so much for letting me be here today. It's really a delight.